afternoon, everyone. Welcome to Stratus Health's Introduction to Minnesota's Reducing Healthcare-Associated Infections Initiative. My name is Jill Keither-Anderson. I am the Program Manager for the hospital HAI work. I look forward to working with all of you in your quest to reduce, if not eliminate, the majority of HAIs. Today's webinar will provide an overview of CMS's quality goals and strategies, the HAI initiative, how we are integrating this work with other Lake Superior Quality Innovative Network initiatives, and we will discuss the benefits of participating in this initiative. There should be time at the end of the presentation for any questions. I'd like to begin by talking about the change that occurred last August to the QIO program. CMS decided to make changes to the QIO program, and first decision they made was they wanted to divide up the work that the QIOs had been doing for years. They said a QIO could no longer do both the beneficiary protection work, such as case review activities, and the quality improvement activities. Next, CMS changed the name of the QIOs and their makeup. The QIOs are now called Quality Innovative Network QIOs, and the makeup of a QUIN QIO had to be a network of at least 3 in no more than 6 states. The purpose of this change was to increase efficiency and strengthen the quality improvement efforts. So Stratus Health has partnered with MPRO in Michigan and Medistar in Wisconsin to become the Lake Superior QIN QIO. The three of us have been QIOs in our respective states for years, and now under the new name of Lake Superior QIN, we continue to support the CMS quality initiatives across the continuum of healthcare in our respective states. Healthcare-related harm statistics. It's known that HAI prevention is paramount to preventing patient harm. The Centers for Disease Control and Prevention have statistics which show there is still much work that needs to be done to improve quality, patient safety, and reduce unnecessary costs of care, all a part of the triple aim. Statistics show that more than 1 million HAIs occur each year at a cost of approximately $30 billion. 1 out of 25 hospital patients acquire at least one HAI on any given day. 30 to 50% of antibiotics are inappropriately prescribed in hospitals and skilled nursing facilities. Poor coordination of care can lead to unnecessary hospitalizations. These are all good opportunities for potential cost savings. CMS National Quality Goals. From this diagram, you can see that at the center of all quality initiatives is the patient. And one of CMS's major goals is to make care safer by reducing and preventing harm caused in care delivery. Multiple strategies must be used to accomplish the national quality goals, as shown in this diagram. So CMS's quality strategy. To accomplish these goals, strategies such as patient and family engagement activities, HAI prevention, and use of evidence-based guidelines for care must be employed. Other strategies include having an antimicrobial stewardship program, which this topic has been in the news a lot lately and has become an additional national priority. Additional strategies are public data reporting and transparency, as well as reducing unnecessary readmissions. The National Action Plan to Prevent HAIs is a roadmap to HAI elimination. This Department of Health and Human Services document provides the foundation to accomplish our HAI reduction and prevention goals across the continuum of care and provides metrics to monitor progress in meeting these goals. The HAI Initiative overall goals. The overall goals of this HAI initiative seeks to decrease HAIs as exhibited by the reduction in the HAI standardized infection ratio, also known as SIR. Also to decrease urinary catheter utilization, improve the culture of patient safety, and decrease unnecessary readmissions related to HAIs. Michelle Nordwall, our analyst, will speak to this next slide.
Yeah, the table on this next slide shows the standardized infection ratios for Minnesota and the nation for various HAIs. So the standardized infection ratio, or SIR, is the actual number of infections divided by the number of expected or predicted infections. So when you're looking at SIR data, lower is better, and 0 equals 0 patient harm. And if you see a SIR greater than 1.0, then that means that there were more observed infections than were expected. So this hospital compare data shows that Minnesota is above the national SIR in both CODI and SSI colon surgery. And those are also areas where we are having more than expected, as you'll see by the SIR of greater than 1, just like the nation is too.
Thank you. The LSQIN initiative integration. This diagram depicts how HAI activities are integrated across the LSQIN path. The hospital HAI reduction and prevention efforts can provide additional benefits across other settings and initiatives, which is explained further in the next few slides. Care coordination is a key strategy that has the potential to improve the effectiveness, safety, and efficiency across the healthcare continuum. HAIs can be acquired anywhere healthcare is delivered. HAIs can contribute to increased admission and readmission rates. The elimination of HAIs requires an all-team coordinated effort across the continuum of care and aligning care across our healthcare silos to help improve collaboration among care teams and patients. Care coordination is a current initiative that is available for participation through the LSQIN. Each state is recruiting communities of care to work on reducing adverse drug events, hospital readmissions. We are recruiting hospitals, skilled nursing facilities, home health agencies, pharmacies, community pharmacies, assisted living facilities, senior programs, and beneficiaries within a community to work on improving coordination and transition of healthcare from one healthcare provider to another and to the beneficiary. Another initiative that LSQIN is working on is reducing healthcare-acquired conditions in the nursing home setting. Nursing homes have an increased need to focus on implementing infection prevention best practices to minimize HAIs and decrease patient harm. Collaboration between these two initiatives, meaning the hospital HAI and the nursing home work, is paramount in addressing infection prevention best practices related to UTIs, appropriate catheter care processes, Clostridium difficile infection, antimicrobial stewardship, vaccine administration, and other infection prevention strategies. HAI and meaningful use. As the healthcare shifts to a model that reimburses based upon value over volume, facilities look to technology to assess how they can best use it on a larger scale to lower costs and improve care quality. To take advantage of technology, organizations must leverage the electronic health record to the greatest potential to impact patient care. HAI interventions can be optimized using health information technology. For example, customized alerts to check for unnecessary urinary catheter utilization has been one way some of the providers have used, and another example is patient care portals to share information while improving patient involvement. The other initiative within this integration of work is value-based purchasing. CMS Quality Incentive Program was built upon the hospital inpatient quality reporting measures. VBP rewards value, patient outcomes, and innovation instead of just volume of services. As you can see from the diagram, for fiscal year 2017, there are 4 domains to determine your hospital's total points. Hospitals will be evaluated on a safety domain where HAI outcome measures are used to calculate achievement and improvement for an incentive payment from CMS. This safety domain accounts for 20% of the total score. HAI data included in the safety domain include CLABSI, CAUTI, SSI, and added this year are CDI and also MRSA. HAI prevention and reduction is essential in lowering costs and potentially receiving an incentive payment for performance rather than being penalized by a reduction in payment. LSQIN HAI Initiative Project Goals. Our HAI Initiative goals have been developed to target the reduction and prevention of CAUTI, CLABSI, CDI, and the reduction of device utilization days. Our goals are to improve reporting and transparency in data, foster local innovation and learning in an all-teach, all-learn, all-share environment, and to engage patients and families in their health care. For example, doing bedside rounds and having providers invite them to participate on quality or safety councils within their hospitals. Specific to this HAI work, and we all work of the work of the QIOs, we are inviting beneficiaries and patient representatives to our educational presentations. Recently, we've invited a beneficiary and their representative to participate on our CHAIN Leadership Council. The value for your organization. The value this brings to your organization is having access to HAI national, regional, as well as state experts and resources. Also having opportunities in our state and the regional network to engage and compare yourself with like facilities. And the financial impact with HAIs affects a number of initiatives. One previously mentioned was BBP, and others include healthcare acquired conditions and readmissions. What can we do for you in this initiative? We will offer one-on-one technical assistance, which can include performance improvement assistance, including root cause analysis, intervention selection, and measurement. We can provide assistance with monitoring progress with your efforts, training on various change strategies, such as team steps and CUSP, which stands for Comprehensive Unit-Based Safety Program, and use of evidence-based protocols for better care for patients and cost saving while eliminating variances in care processes, which will help to standardize processes. We understand that hospitals are at different places in their HAI work, so we will meet you wherever you are at and lend our support there, because the goal is the same for everybody, and that is eliminating HAIs. Additional benefits to participating in this initiative are throughout our support center, known as the NCC or National Coordinating Center, we will have access to the most current tools and resources created by providers in other states working with their QIN QIO partners. We'll have access to HAI national, regional, as well as state learning sessions, and we'll have opportunities to hearing from like facilities in other states and have opportunities for you to share your success stories across our region. I mentioned earlier CHAIN, that we had invited a beneficiary and a representative on there. And for those of you who don't or have not heard of CHAIN, here in Minnesota, our Learning and Action Network, also known as LAN, is called CHAIN. And that acronym stands for Collaborative Healthcare Associated Infections Network. That was started in 2013. And CHAIN is 4 agencies who have partnered to work on HAIs collectively by inviting leaders in healthcare to help determine major priorities and strategies for hospital HAI reduction and to identify and address culture change strategies. CHAIN also has an operations group to help facilitate making these changes happen. While QIN QIOs do not work on all infections in this particular contract that we're in, this partnership with CHAIN, we have all of the infections covered because our partners are the Minnesota Department of Health, the Minnesota Hospital Association, and APIC Minnesota. Additionally, what we can provide is NHSN HAI data feedback reports, including TAP reports, which stands for Targeted Assessment for Prevention. The TAP strategy is a new report that became available in February, and these reports can rank your locations and units by the number of excess infections identified, which is calculated by the cumulative attributable difference, also known as the CAD, which all is mouthful. CAD is the number of infections that must be prevented to achieve an HAI reduction goal. So the CAD can help to prioritize locations where the greatest prevention impact can be achieved. We will be offering education on TAP reports on a regional basis, meaning with our partners, Wisconsin and Michigan, in the coming months. Now I would like to introduce Robin Carlson, the Quality Reporting Specialist here at Stratus Health, who will speak to the reporting requirements.
Hi, everyone. Excuse me. As this slide shows, the monthly submission for your CADI, CLASI, and CDI data is required for the HAI initiative. Now, that was in the participation agreement. So I'm hoping that everybody's noticed that. I pulled one up to see to make sure it wasn't in like the really small fine print, and it's there. So hopefully, like I said, that's not a surprise to anyone. But we know that that's different than the inpatient hospital reporting program requirements, which are quarterly. But to do the work, that Jill has talked about, and then to get the graphs that Michelle is going to show you in a couple of slides, we really need to have that data entered on a monthly basis. So the deadline for submission of your HAI data in NISN is going to be the last day of the next month. And that sounds kind of complicated, but I couldn't really find a better way to word that. So the next slide kind of shows you a couple of examples. So July 2015 data would be due by August 31st. August 2015 data by September 30th, September 2015 data by October 31st. And so on. I think that you can see the pattern there. So what the plan is that we'll check NISN the day after the due date, and then you'll be notified by email if your data has not been submitted. So once the project gets going, we can kind of see if that seems like that works for everyone. I didn't want to send out reminders, just general reminders, because I think everybody gets enough emails. So we were kind of just hoping that once you get, once we really start going with this, it just becomes your pattern, and then, we don't have to bother you with those reminders. But if people seem like they need them or they want them, we can always make adjustments. So then I'm going to turn it back over to Michelle, and she's the analyst for this project, as Jill said, and she's going to show you the types of graphs that we'll be sending out.
Yep, thanks. So most of you probably have already received some graphs that we are going to be providing for you as part of this initiative. And so on this slide and the following slide, I have examples of those graphs using some fake data. And so on this graph, this is a sample of the CADI data report, which you will receive if you are participating in the CADI initiative. So this graph, you'll also, if you have multiple units, you'll get a similar report for each individual unit, as well as a report like this where we combine the units. And then if you're part of Class C or CDI, you get a a report very similar to this, but it's actually a little less complicated because you don't have, things like catheter utilization rate and things like that. So, and for CDI, that's facility-wide, so you wouldn't get any kind of unit-level reports for that one. But on this graph, the kind of the tan or beige shaded area in the background is the number of patient days. The blue line is the number of catheter days, and then the blue dots indicate how many infections you had. And you can see this is all monthly data. And then in the table below, it will show your actual data, and then it also includes a CAUTI incident rate and a catheter utilization rate. And then on the next slide, this one is an example of the SIR report that you'll receive. And remember, a SIR greater than 1 means that you had more infections than expected. So that's why we include that red kind of SIR of 1.0 line there. So again, this graph would show, if you only have one unit participating in this initiative, you just see one line. But if you have multiple, you'll be able to see both the line and the data for your multiple units, as well as the kind of a combined data. And again, if you're participating in Class C or CDI, you get something very similar to this, and basically the CDI would just be facility-wide data, so it's not broken out by unit. But those are examples of some of the reports that you're getting right currently, but we would really appreciate any feedback on how to make these data reports even more valuable to you, and or what kind of data reports you'd like to see in the future. I know we're talking about creating something that utilizes the TAP report, so any suggestions would be greatly appreciated.
Thanks. Thank you, Michelle. And any comments or feedback regarding those graphs, you can certainly forward to me, and our team here will look those over and potentially change or ask for clarification regarding any questions or suggestions you may have. This slide, resources, just speaks for itself. The first resource I listed up there, because there are hundreds of different resources, but of course I want to talk about the ones that we use most. The first one is our CHAIN website, and that is where you'll find the Minnesota Roadmap to a Comprehensive HAI Prevention Program. This roadmap provides evidence-based recommendations and standards for Minnesota hospitals in the development of the Comprehensive HAI Prevention Program, and that includes CAUTI, Class C, VAP, SSI, and CDI. Soon, the CAUTI bundle will be updated from the work that has been done by hospitals working in Cohort 9, which ends in the month of August, and they also have been a part of this initiative. We started work with them in partnership with MHA back in December of last year, and the MHA component ends in August, but we will continue to support those providers going forward throughout our contract. Next is the ARC website, and they have many resources. A lot of resources there can be similar to ones you may find on CHAIN or on the Hospital Association. Then there's the CDC website, and they have a lot of new updated information. And the last I put on is our LSQIN website, where you will find resources and tools from all 3 states. So next steps. I would like to let you know that the LSQIN has created a facility needs assessment that I will be sending out to the contact person at each hospital for this initiative within the next 2 weeks. This is an optional tool that we encourage you to complete because it will help identify facility needs that, if work done and addressed, can help you meet your HAI goals. In September, we also will be offering a CAUTI assessment tool. That will be in the form of an electronic survey that we would ask your staff to complete. We would then take that data, analyze it, and send a report back to you. There also is a CDI assessment tool that is being piloted right now, and both the CAUTI and CDI tool are actually tools that the CDC has generated, and these tools are not available on NHSN. These are tools that were made for QIN QIOs to use with their providers. Again, if you are not doing CDI, and because we would be sending out the tools to everybody, but if you're not doing CDI and you'd like to do the assessment, you are more than welcome to do that and would receive an analysis and a report to that. Also, a next step is that I will ask Mary Monterey, our program coordinator, to get in contact with those of you that I have not had an initial call or visit with, to set up some time in the next month or two so that we can have a discussion regarding your current work, your goals, and measures, and to help identify the support and tools you need to meet your HAI goals. Here is our contact information should you have any questions. And at this time, I would like to open it up for questions.
The floor is open to your questions. If you have a question or comment, please press 7 on your telephone keypad. Again, for a question or comment, please press 7.
Well, we'd like to thank all of you for participating on this introductory kickoff call for the HAI work that we are doing, or that we will be working with all of the providers going forward for the next 4 years. Again, if you have any questions or questions, please feel free to email or give me a call. We thank you for participating, and we will be talking to all of you soon. Thank you.
Thank you. To conclude today's teleconference, we appreciate your participation. You may now disconnect your line at this time.